is several years ago. I think 2021 was the first time that the bill was attempted in a different form than what we passed. And so the South Dakota Academy of PAs brought a bill, attempted to pass it, thinking that this is going to expand access to care. Nurse practitioners achieved it within our state in 2017. That bill failed. It did not make it out of committee, is my understanding. The following year, attempted again, and again, another failure. The third year in a row, we failed. And at that point, it's like, okay, what are we doing wrong? How do you change this? And I would speak to, the audience here that we're all capable of doing this, that we all have the potential to see a problem and to fix it. But how you fix it may need some toying with it, right? How many times did it take to create a light bulb? So with this, we took a year off. 2024, Kayla took over as our legislative chair.
Americans are capable of achieving extraordinary things when they have the freedom and opportunity to do so. This is American Potential.
Welcome to the American Potential podcast. I'm your host, David Fromm. When you're not feeling well, whether it's something short-term or a chronic condition, you want to be able to talk to a medical professional who can help you feel better or manage your symptoms. It's true for everyone, but it can be especially challenging for people living in rural areas where access to healthcare providers is often limited. But here's something you might not think about. Just like patients face barriers to getting care, healthcare providers sometimes face barriers to giving care. That's been the case for physician associates, or PAs, in South Dakota until recently. This past March, South Dakota passed a new law that removed a barrier for PAs to care for patients in the state. So how did this change come about? It was the result of years of advocacy, and supporters of the bill said it would cut red tape, reduce administrative burdens, and help more patients, especially in underserved areas. Today's guests worked on getting the bill passed, so I want to welcome Kayla and Echo Kopplin, who are both physician associates in South Dakota. Kayla, Echo, welcome. Thanks for joining us.
Thank you for having us.
Yeah, that's great.
Before we talk about the bill and the work you all did, why did you all decide to be physician associates in the first place? Kayla, let's start with you.
I have always really enjoyed science and kind of explored some different options on how to use that in a career. I come from a family of teachers. My dad was in the military. I didn't really have much exposure to medicine. The thought of going to medical school to become a physician was very daunting to me. Really, I received care from a physician associate when I was growing up. That's the only person I knew as a primary care provider. So really explored that option. And I just really liked the flexibility to be able to move between different specialties, and just the kind of dynamic nature that the profession allowed. So kind of started down the path and never looked back.
Nice. Echo.
Yeah, I had a similar experience. So I grew up in a very rural community in northern Nebraska, and the only care provider for our family was a PA. And I have some health history my own self that this PA didn't know much about, but chose to find out everything that he could. And he really did become such an influential part of my path.
Wow. So both of you was really experiential. That's really pretty fascinating and pretty informative, actually. So Echo, what does it take to become a physician's associate?
Yeah, so I went to undergrad, got my bachelor's degree, and during that bachelor's degree, you're completing all of the medical prerequisites. So same thing that my med school pre-med colleagues were taking. During that time, you're also obtaining patient care hours. So most PA programs require, I think, an average of 1,000 hours, but oftentimes more than that for patient care experience. For myself, I studied athletic training. Most of those hours were not counted because I was not in direct patient care. So it's not just, I was at a clinic and I'm going to count those hours shadowing. It is truly direct patient care experience. Once you complete that bachelor's, you do have to take a prerequisite test, such as the GRE, or there's a new test called the PA-CAT, which is comparable to the MCAT in that standard of science background that you need to have. You apply, you take the interview, and then once you're accepted, you go through a master's level program, which is that PA school program. And the curriculum is very standardized. We have a governing body that makes sure that each school is accredited, and you cannot obtain you cannot graduate or matriculate unless they have that accreditation. Throughout that, you are doing your didactic portion of classes, and then you move on to a clinical portion of classes or schooling. And so during the clinical year, there are 6 required clinical rotations, and each school has kind of a variance of that. But during that time, you're really getting the general medicine education. So we all come out as generalists to work in primary care to serve the underserved. Specifically in South Dakota, the USD PA program has a specific, you have to do a rural or underserved family medicine rotation. Not all programs do that, but many do. Our goal is to serve those underserved communities. So to kind of highlight, you get your 4-year bachelor's degree, you go on and you do a 2 to 3 year master's program. And then after you graduate that master's program, then you have to take your national certification exam, which we call the PANCE, the PA National Certification Exam. That is a 5-hour test that you sit for at a standard testing center. And you complete that, and if you pass, you can then go on to obtain your state licensure and go through finding a job. Now, if you do not pass, you have to wait a certain period of time, just as any other professional degree with a national certification, and then you can attempt to retake that exam. We do retake that then every 10 years to make sure that we maintain certification.
What was the difference between, now that this bill is passed, is there a difference in preparation at all that you all had to go through, which going forward might be different, or is the education requirements and the preparation the same? And there's just some other aspects that are changed.
It's going to be the same.
Okay.
Yeah. So really, our bill doesn't touch any of that process that Echo talked about. The training, the education, the standard we're held to both from the national accreditation organization and then our local universities that provide these programs is completely unchanged. Where we really are seeing the change is at the licensure level. That's really where kind of we found this bottleneck and this problem. And so we sought to find ways to solve it.
And I think one of the issues is around physician oversight, if I'm not mistaken. Kayla, maybe can you talk about some of the struggles there?
Yeah, and I think one of the reasons Echo and I both kind of really became very involved in this advocacy issue is that we both had personal experience with trouble with this red tape barrier. I'm originally from South Dakota. I trained at the University of South Dakota, left the state for a few years, and then came back in 2020 and tried to get a job here in South Dakota and had a lot of trouble because part of our licensure process is you're required to have and for a couple more weeks until July 1st, when this bill goes into effect, you're required to have a specific physician listed on your license, on file, a hard paper copy on file with the Board of Medicine. But employers, sometimes it's kind of a chicken and the egg situation where employers don't want to hire you unless you have your license, but you can't really get your license without a supervising physician. So I found when I was looking for a job when I came back in 2020, I was unable to get a job because my license wasn't fully done, and nurse practitioners don't have this barrier. A lot of times jobs, especially in the Midwest, we find are listed for a PA or a nurse practitioner. And so they had less administrative burden and red tape and were easier and to be hired and onboarded. So I came to the state with, 7 years of experience, good primary care experience, and I couldn't even get interviews. So when the opportunity came to kind of work on this bill, I jumped at the opportunity because it was something that I experienced firsthand.
Yeah. So, Echo, maybe take us through how this bill came about, because I know there's a history to it.
Yeah. And Kayla, correct me where I'm wrong here, but so several years ago, I think 2021 was the first time that the bill was attempted in a different form than what we passed. And so the South Dakota Academy of PAs brought a bill, attempted to pass it, thinking that this is going to expand access to care. Nurse practitioners achieved it within our state in 2017. That bill failed. It did not make it out of committee, is my understanding. The following year, attempted again, and again, another failure. The third year in a row, we failed. And at that point, it's like, okay, what are we doing wrong? How do you change this? And I would speak to, the audience here that we're all capable of doing this, that we all have the potential to see a problem and to fix it. But how you fix it may need some toying with it, right? How many times did it take to create a light bulb? So with this, we took a year off. 2024, Kayla took over as our legislative chair, and she really went back to the grassroots effort. How do we achieve this within South Dakota? And figured out we need to make those relationships with the legislators. What were we doing wrong with that first bill? Was it a communication issue? Was it a bill issue? And I think that there were both addressed that Kayla was able to find. Another thing was finding out whether we needed to continue with the same lobbyist or find a new firm, right? So we took 2024 off. We didn't bring any legislation, but we were still present. We went to the Capitol. Kayla was able to host a PA day and set that up. And so we had a day at the Capitol where PAs from around the state were able to come, meet with legislators. We had a good opportunity there. And then in the summer before our legislative session this year, we started meeting with legislators, phone calls, coffee, building those relationships, talking about bringing a bill, meeting with stakeholders, saying, what do you like about this? What do you dislike? What would make you support this?
Wow. Working at AFB, we're a grassroots organization, and that is the textbook as to how you advance good legislation, because people don't realize, this stuff doesn't just happen all of a sudden. Legislators, like anyone else, need to learn, be convinced, get a comfort level. Some have biases, some don't. And then you also change legislators. And so they need, there's continuing education. So what you just described is just such a great grassroots approach to trying to educate the legislature and pass better policy. So that's really awesome. So you each were working at the Capitol to get this passed. Can you talk about, what you all did? Kayla, maybe you can go first.
Yeah. So one thing that I felt very, very strongly about is trying to I think we live in such a polarizing political environment right now. And I think access to healthcare should be something that no matter how we do it, it should be on everybody's agenda. But I was really adamant about trying to keep it as positive and as patient focused as we could. Our main opposition were physicians. I think a lot of times there's a misunderstanding about how day-to-day practice actually works with PAs. And so we kind of came across some opposition from them. But really the way we did it is just how Echo described. Echo and I were at, South Dakota is a little bit different. We have a very short session. So we run, 4-day weeks. Our legislators have to travel, quite a bit to get to our state capitol in the middle of the state. And Echo and I stood in the state capitol 2 to 3 days a week, the entire session. We kind of were dividing and conquering. And yes, we were there to talk about our bill, but sometimes it's just about being present, showing up all the time, showing that this is important to us, just us taking time away from our families and our jobs and being present to answer questions. It's not always trying to hound somebody about what the bill does or what it doesn't do, but just being available, we found was really, really helpful. And we just tried to be really positive. We tried to keep it about what we do as PAs, how that can help our state, and tried to keep kind of the negative talk about what other professions were doing or what other professions' opinions of it were out of it, try and keep it as positive as we could. And I think legislators really appreciated that in today's political environment, just trying to keep the focus on the goal and not the competition, at the Capitol.
Yeah, I think a lot, I know from experience that the physicians and their lobbies are some of the most powerful in a lot of state legislators. So I think that you guys taking that approach where it's like, hey, get to know us, build trust with us, listen to what we have to say is such a great, authentic approach to, trying to pass better legislation, overcome those objections. Echo, what were some of the concerns that you heard from legislators?
Yeah, I think there was a lot of concern around the title independence, right? That word is kind of a buzzword, it seemed like, within our capital of, oh, you're going to have independent practice. Well, I kind of already do. In my own PA practice, I practice autonomously, where I'm seeing patients where there is no physician seeing those patients unless they have a specialty caregiver. So I practice in primary care. If I refer them on, maybe they see a PA in that specialty that I refer them to. Maybe they see a nurse practitioner. Maybe it's a physician. But that's a team. That's our collaborative approach to healthcare these days. So one of the barriers that I encountered every day, I think, that I was at the Capitol was that, well, you're trying to get independent practice. Well, okay, let's break that down. What do you mean by independent practice? Are you saying you think we're going to go and open our own clinics? Well, we can already open our own clinic, even with law the way it is today before our bill takes place July 1st. There's a lot of I guess people don't, a misunderstanding, I would say, around that title of independence.
Unless folks, I'm actually pretty familiar with South Dakota, and really, unless you live in the Sioux Falls area or Rapid City, it's pretty sparsely populated. And so can you maybe describe to me how physician associates fill a need to kind of cover the healthcare needs of people throughout the state, and like what that looks like practically?
Yeah, I mean, I think a big piece of it is, you really feel it the most in rural areas, but nationwide, there's a physician shortage, right? So physicians are aging. We have an aging population that's living longer. We're just not meeting the demand. And that's really where our profession was born out of in the 1960s, taking military members, training them with a physician, working them side by side, and kind of to help fill those gaps. So in South Dakota, I think a lot of times we do see PAs or nurse practitioners in rural areas, not only managing clinics, but managing critical access hospitals. I talked to a lot of PAs during our grassroots kind of effort to understand, it's important from an organizational standpoint to understand what the bill will do, but talking to actual PAs in rural healthcare, what parts of the bill worked well for them, didn't work well for them. And these PAs are covering small critical access hospitals with clinics, nursing homes, urgent cares all attached in one building and just completely taking care of their community. I think a really important aspect of our profession in our state, too, is it allows people to have providers that are parts of their community, right? So you see a lot of PAs in South Dakota that are from a small town, maybe a few thousand people, that grew up in that town, that know everyone in that town, that know the history and the intricacies of that town, and they go off and get trained, and then they come back and they're able to take care of their own community. I think we just don't have the number of physicians to kind of to take care of all those little tiny towns, and we find there's a lot of places that's their only access to healthcare for hours, is maybe a PA or a nurse practitioner. And a lot of times too, we see them working in conjunction. Maybe there's one physician, but they have two PAs and a couple nurse practitioners, and that collaborative kind of community environment. They're able to provide all those services to small communities.
And do you see this being impactful also for the Native American population, who are even more impoverished in rural areas?
I would say that we kind of encountered this. There was a couple of legislators that were, that was their constituents is the Indian Health Services. And how does this affect and what goes on here? And one of the big things that we found in kind of exploring that, because I was like, oh, I don't have an answer to your question, but I'll come back. We'll find out. What we were able to find out is it really can impact them from the state level, in that currently they were unable to hire PAs at the, rate that we would currently look for a salary, when they could hire a nurse practitioner without the extra red tape, when they would have to, in our state, with a supervising physician, that physician often wants to be compensated for their time supervising. So when you look at, I have a PA that I also have to pay a supervising fee, or I have a nurse practitioner, I don't have to pay that supervising fee. Which am I going to choose?
You've touched on some of the aspects of it here, but I mean, maybe if you had to sum it up, maybe when you were going to give your pitch to a legislator, how will this bill being passed now that it's in law, and when it goes effect on July 1st, how will this benefit the people of South Dakota?
One thing we were really adamant about in the 3 years where we failed with this bill, we really pushed the rural healthcare aspect of it, which, yes, it will help with.
Yeah.
But we didn't really focus on that this time. We just looked at it from a purely administrative kind of standpoint of we don't have nurse practitioners do this kind of supervision agreement anymore in our state. Why are we making one other healthcare profession do it? Kind of keep it an even playing field. I think a big piece of it too is really looking at how our profession has evolved. And we're having this name on a piece of paper just to kind of check a box, not necessarily because it translates into patient care. So I work in a group there are 10 physicians in my group. I have one physician listed on my license as my supervisor, but I may not see that physician for months. I may not work, directly with him. So how is that translating to patient care? And also it allows for organizations to create their own, I don't know what the word is, Echo, to kind of keep local control, right? So if my facility wants to have a different structure, we shouldn't all be held to the same structure for a supervising or collaboration agreement. My practice in Sioux Falls, the largest city in the state, is going to be different than someone who's practicing in Selby, a town of 600. So letting us formulate our teams in a way that works best for our organizations and our patients, rather than just doing things to do things to check a box for the Board of Medicine.
Yeah, I agree. Let's remove that red tape. And I apologize, David. Let's remove that red tape. Let's improve that flexibility within the healthcare team and let the community serve their community to the way that they see fit.
I think a piece of it too also goes with, so I work in Sioux Falls. If I would want to go and pick up some hours in a rural ER a couple hours away, I would require a new supervision agreement, a new supervising physician in order just to do that, to pick up that kind of those extra hours. For every practice location you have to have a supervising physician at that location. It just really limits the flexibility of PAs to provide care in different avenues, in different places, and hold multiple positions, which a lot of times in healthcare we do. You may have your primary position and then you may fill in and kind of help out on the side. So I think it helps that flexibility piece.
One thing that we see around the country really is that, healthcare is one of those industries that has a lot of, kind of red tape and I'd say even sometimes protectionist policies where, we think that expanding access to healthcare, allowing more people to participate in the industry and be able to benefit patients is going to help drive down costs and give people more access and have better health outcomes. And, and it's not necessarily dependent. It's not necessarily reflective of like a red or blue state or anything like that. It's pretty pervasive. Unfortunately, we see that in a lot of industries, really. And so, we've been talking a lot about reducing regulation and red tape so that, we just distill it down. Look, we want people to be competent at their job, especially in the medical world, and be able to deliver good service and not endanger people at all. But it's really gotten out of control in a lot of places over a number of decades. And unfortunately, sometimes it's the industry is preserving their own self-interest. And so I think what you guys did, like, what a great grassroots effort to educate the legislature and get much better policy. That's fabulous.
Yeah, I think Echo can attest to this. I think grassroots is my least favorite word in all of advocacy. I mean, because it's such a nebulous thing. What is, when I took over this position, everyone was like, oh, we really need to amp up our grassroots. Well, what does that mean? What does that mean? I wish there was a do this, then this kind of flow chart for grassroots. But the unfortunate thing about it is that every state, every environment, every legislature, every issue is got a different playbook, right? And so that's really what we did in 2024 is we just stepped back and we completely scrapped everything. The bill, the strategy, the talking points, everything just went away and we just built everything up from the bottom. And I think it's just kind of almost like my kids love the book, If You Give a Mouse a Cookie.
Yeah.
Kind of that idea of you do one thing and then it leads to another idea or another phrase that you can use with legislators or another community partner you can find. And it's just this like kind of web you weave of just doing the next thing in front of you. That's, I think, the best way I can describe grassroots at this point after, living it for 2.5 years. But I hate the word, but it's a powerful thing when you kind of tap into it.
I mean, it's just a way of saying like what you guys did. You amplified and aggregated the voices of people who had something to say, like towards a common purpose. Like you took the people who were really doing this job and who would benefit from a change and connected those voices with the decision makers. And that's how you made change. And I think it's a super great story. We have this campaign that we're starting up soon in Americans of Prosperity called the One Small Step campaign. And it's about like so many people who have made dramatic change for freedom and liberty and more opportunity in this country have just made one small decision to get involved or to take an action, maybe take a risk. And it's had dramatic benefits in shaping, this wonderful country. You guys are part of that. Huh. Well, I really appreciate you guys coming on and sharing your story with us. And I mean, frankly, hopefully people of South Dakota can be thankful for, better medical outcomes and access that you all have helped.
Expanded opportunities for everyone. That's
great. Well, thank you both for coming on and talking about the Physician Associates and the work you did on the bill. Folks, if you like this episode and would like to stay connected with the podcast, be sure to like and subscribe our YouTube channel, as well as following us on Facebook, Instagram, and YouTube. Always remember, liberty and freedom are easily taken for granted. Don't take it for granted. Go out there and defend freedom and liberty. Thanks for joining us, and we'll see you on the next episode.
Thank you for listening to American Potential. You may listen to more stories from Americans working every day to expand freedom and opportunity in their communities by visiting AmericanPotential.com.